Good afternoon.
Good afternoon.
How are you today?
Hello.
Hi.
Um, I have a question, which I figured it's okay. I have my complete anatomy on my iPad, so
hmm
I'm going to join with both, and that way, when he calls on me, I'll just screen share from the iPad. I've already tested it. It does work.
Okay. Um, he did a little demo of complete anatomy today and kind of showed what he's looking for. He didn't
Oh,
have the students do much today in the first
oh,
group.
thank God. I was
We've
kind of
kind of
scared.
we'll kind of take you guys through it today, and then you can be prepared for what to do for Thursday.
Okay, that sounds good. I'm a lot less anxious about it now. I was like, oh my God, this is kind of
Yeah,
hard.
I asked if he would do a little tutorial because there have been some questions. So
Thank you.
you're welcome. Happy to help. I'll announce it a few more times, but if you guys have skeletons, I would grab your skeletons for today as well.
Okay, I'm gonna go run and grab mine then.
Yeah, give you guys some time to do that. Hmm. Hi, CJ. Hi, Rita. If you guys would like to bring your skeletons close to you, you'll need them today. Hi, Gina. Hi, Dr. Warren.
Hello, Dr. Lang. Did you have a good lunch?
I did. It was a quick lunch.
You had another meeting, and then you had a couple minutes to eat.
Yes. Yep. Tuesdays I always have the meeting for clinical ed between the two sections. So
Tuesdays are long days for Dr.
th
Lang.
they are. Luckily we take turns, but office hours for professional formation is at 7 a.m. here.
Wow. Yeah, that is a long day.
So for those of you that are just joining and aren't on camera yet, if you can grab your skeletons, we will use those today. You can use an anatomy book, CJ, or you can also just try to palpate on yourself. Hi, Melina and JD. In case you haven't heard, if you have a skeleton, go ahead and grab that. We'll use it a little bit for the first portion today.
think everybody's here.
Is Dave, I think David we're waiting
Uh,
for.
there he is.
All right. So before we get started, if you don't have your skeleton right next to you, if you want to grab your skeleton and bring it near you, we'll use it for the portion where we review the osteology today.
All right, make sure all of your cameras are on for us, please. Thank you, John. Erica, are you there?
Yeah,
She's on her iPad too, so.
Uh,
that's
oh, I
for
see that.
complete anatomy. Yeah.
There's two Ericas. Okay, so my announcements here at the beginning, of course, I'm certain that you all have seen the exam scores already for exam one. Dr. Ling and I are very happy, more than willing to talk with you about your exam. The way that will occur is if you will email the two of us so that the three of us can join in an email chain to find an appropriate time that we can all three meet. We will we'll discuss with you topics that you may have missed on the exam. We cannot show you the exam and we cannot read you test questions, but we can talk to you about. So you put parasympathetic instead of sympathetic. And so we say to you in our question, tell us about the sympathetic motor output. Where in the spinal cord does that come from? And then you answer the question or you don't. And then that gives us some clues as to whether or not you have some things that you need to make up. In other words, this content is not going away. It'll show up on your comprehensive final exam as well. So very briefly, for outline for today, Dr. Ling is going to talk osteology and ligaments and joints, joint actions with you for the first portion of the class today. During the second half of the class, I'm going to give you a global kind of top-down things that you know, but you didn't put them together like this kind of presentation to start talking about dermatomes and myotomes. And then I'm going to give you a strategy for learning brachial plexus, and I will model that for you in complete anatomy. Right toward the end of the first hour today, 2 or 3 of you, I will ask to open complete anatomy so that we can share screens and make sure that's working. So if you want to go ahead and double click on complete anatomy and have it open and ready to go for that during the last few moments of the first hour, we'll do that today. Dr. Lang, that's all on my list on the
All right.
announcements.
I was just making sure that they can share. They should be able to now. All right. So let's go ahead and get started. That's not what I wanted. Okay, so we're going to start by going over the osteology and the ligaments. I'm going to give you a little warm up into the motions that occur at the AC joint and the SC joint, because those are by far the most confusing. So if you can start by knowing what I cover today, that'll help to layer on more stuff when we get to the lecture on Thursday. The arthrokinematics are a bit confusing for that region. So let's just start. And for today, feel free to just unmute yourself and answer any questions I have. I'm not going to call on anyone, but hopefully you guys can participate. So this is a little bit of the external anatomy. These muscles you're all going to learn. As you should remember, the armpit is called the axilla. So you'll see the axillary nerve. It's aptly named because it goes right in that region. The jugular notch of the sternum, you'll see that when we get to the osteology as well. Let's talk a little bit though about the placement of the scapula on our thorax. So where on the thoracic spine is it? What levels of the thoracic spine does that scapula sit? And you can guess if you're not sure.
On the upper thoracic spine?
It is in the upper thoracic. Does anyone know the levels?
Is it T3 to T6?
You're close. It's T2 to T7. So that superior angle is going to be at T2. If you follow the spine of the scapula to the medial edge, it's called the root of the spine of the scapula. That's at T3. And the inferior angle is going to be at T7. And this is important because if you're looking at a patient that has an issue in the thoracic region, you don't want to have to count down levels from C1 all the way down. And also, if a patient has a scapula that's in a weird position, it's either high or low, you want to be able to note that as well. Okay, so let's get into the glenohumeral joint. So this is where, after this first slide here, we'll start using our skeletons. First, I want to show you the position of the scapula though on the thorax. So it is a little bit away from the spine, from the spinous processes. It's 5 to 6 centimeters or 2 to 3 inches. It's not quite in the coronal or frontal plane. It's about 30 to 40 degrees anterior to that. And we call that the scapular plane or plane of the scapula. So if you think about the motions of shoulder flexion, everyone do shoulder flexion. We're going to get moving today so we don't fall asleep. Thanks, Dr. Warren. And then if you think about abduction, what does abduction look like? Perfect, out to the side. So then a motion between that in the plane of the scapula is called scaption. So this is a good position to perform exercises. There's lots of room in that subacromial space, and so you'll see why that is here in just a minute. Okay, so now let's look at our skeletons, and we're going to look at the anterior part of the humerus. And I'm going to name off these bone markings, and I want you to find them on your skeleton. These are markings you will have to know well. You'll have to know where to find them. You'll have to be able to palpate them on yourself or on a classmate. You'll also have to know what muscles attach to them. So to start studying them, I would read through the list. I put a list on Teams. I put that whole complete shoulder packet that I showed you guys, I think last week. I put that on the Teams folder. So there's a list of all these bone markings there. So start by just using your skeletons and finding all of them. And then as you progress, as you point to, say, the lesser tubercle, you can say that the subscapularis attaches here. So that's how you can progress quizzing yourself. But let's start with the head. So you have the head of the humerus, and then you have the anatomical neck, and this is where we're going to have a lot of the ligaments in the capsule are going to attach. Now, if we go laterally, you're going to have the bigger of these bumps. So tubercle is a bump, and it's because of a muscle attachment. So you have the greater tubercle that's going to be laterally. Next, moving medially, you have the intertubercular sulcus or the bicipital groove. That's for the long head of the biceps. And then medially, you have the lesser tubercle. So you guys should be able to feel on your shoulder. If you feel lateral, you should feel the lesser tubercle. And then if you come a little, or the greater tubercle, excuse me. And if you come medially, you're on that intertubercular groove. So if you internally and externally rotate your shoulder, you should feel the groove moving underneath your fingers. Below the two tubercles, you're going to have the surgical neck. And this is an important area because this is where we have a lot of humeral fractures, and the axillary nerve runs right here. So if someone has a fracture here, they can damage the axillary nerve. Coming a little bit more inferior, you have the deltoid tuberosity. And this on a lot of skeletons, tell me what it looks like on your skeletons. What do you guys think? So it's laterally about a third, the proximal third of the, oops, it's the proximal third of the there we go. The proximal third of the humerus is the deltoid tuberosity. Is it pretty prominent on your skeletons? No, not really. So you may feel just a slight change in the bone there, but that's the deltoid tuberosity. Now let's move to the back side of the humerus. I'm gonna move you guys out of the way a little bit here. So just on the posterior side of that deltoid tuberosity, you have the radial groove. What do you think sits in the radial groove? What was that? Did someone say?
Radial nerve.
The radial nerve, yes. So you'll see if you can locate the nerve and you can trace its path, it's easy to think about the muscles that it innervates. So then you can see that greater tubercle, how big it really is. You can see it on the backside as well. Next thing I want to talk about is the scapula. So let's start at we'll start on the right scapula, and we'll start at the superior angle, and we'll kind of move around counterclockwise and hit all the bone markings. So you have the superior angle first, and then you have the superior border, which you can see a little bit on this side. It's kind of on both sides of it. Then you have the medial or vertebral border because it's right next to the vertebrae. So medial or vertebral. This is called the root of the spine of the scapula. You may see that. If we continue down inferior, at the very bottom, we have the inferior angle. Going up the lateral side, we have the lateral or axillary border because this is the axilla. You have the head of the scapula with the glenoid cavity on it, and then the neck of the scapula. I'll finish off on the back, and then I'll go to a few more things on the front. So here's the spine of the scapula. So above the spine of the scapula, you have this fossa, or this place for a muscle, and it's the supraspinous fossa. In your lecture, I'm not sure what reference they use, but it did say on the picture that it was the supraspinatus fossa. That's the only time I've ever seen that. So I would say it's not wrong, but it's very uncommon. Supraspinous is going to be what you're going to see more often, and that's where the supraspinatus is. Below the spine is going to be the infraspinous fossa, and this is where the infraspinatus is. If we follow along the spine of the scapula now, you'll see this widening right here, and this is going to be the deltoid tubercle. So deltoid tuberosity on the humerus, deltoid tubercle here. If you keep filling up the spine, and this is a good one for you guys to feel on yourself too, if you keep filling up the spine of the scapula, you will feel where it kind of changes directions and it turns, almost has a 90-degree angle and then comes anteriorly. That's the angle, the acromial angle. And then it forms into the acromion, which is right on the top of your shoulder. The good news is you can't use your skeleton for exams, but you have a built-in cheat sheet. So if you learn to use your body, you learn to find where stuff is, you have it for all the exams. But if you don't train yourself to use it, then you're missing out on a big resource. So if we go back to the front, a few more things to mention. Down here, inferior to the glenoid, you have the infraglenoid tubercle. This is where the tricep inserts. And on the top, you can't see it very well, but imagine the same spot on the top. You have a supraglenoid tubercle, and this is where the long head of the biceps inserts. So we have the acromion that we just talked about, how it wraps around and it meets with the clavicle. Right below that, we have the coracoid process. So if I were to come up and put my hands over the top of your shoulders, my thumbs would be right on that coracoid process. But if you guys go ahead and feel it on yourself, it'll feel like a finger poking out, and it's kind of tender. This is going to be the attachment site for the short head of the biceps, the coracobrachialis, in the pec minor.
And
And is there another one?
short-headed bicep. Did you say that?
I did.
Oh, my bad. It's a test question. It's a test
Do,
question.
do we need to give you some caffeine? I'll pass them on to
I
you.
mean, I'm sorry. I blacked out there for a moment. I just want to make sure. I want to make sure they're having the same experience the first group had.
I appreciate that. And thanks for keeping me on my toes. I'm like, oh no, there's another one. I thought there were only
No,
three. Thanks
just
for
the
making me
three.
panic. So
I missed it.
if you
I
rewind the
didn't.
video, you might see a panic like, oh no, I thought I knew thought I knew this. So this is how you'll test yourself. After you know these bone markings, test the ones that have an attachment. And then on the anterior side of the scapula, this is going to be against the rib cage. This is the subscapular fossa, and this is where the subscapularis is. One more thing that we have that we haven't mentioned yet is this little notch right here. And this is the suprascapular notch. What nerve do you think runs through there?
The suprascapular nerve.
Yeah, there you go. So then you can envision what muscles it's going to innervate from there. I really like this picture because it shows the attachment of some of the rotator cuff muscles, which are really important for you as physical therapists. There's nothing new attached bony prominence wise, but you can see how something like the supraspinatus, infraspinatus, and teres minor, they all have attachments on the greater tubercle, but they're not all in the same exact spot. So you have the supraspinatus on the top of it, and then going down the back side, the infraspinatus and the teres minor. And so by visualizing where these muscles are, this is a good way to start thinking about the actions of the muscles. I'll talk about, I can mention it now. So another way that I recommend for learning the actions of these muscles is to grab a piece of TheraBand or a rubber band that you've cut open and put it on each attachment of the muscle. So this helps you with learning origin and insertion as well as action. So you have the rubber band stretched on each attachment for the muscle, and then watch what has to happen for that stretchy band, whatever you're using, to shorten. That's going to be the action that that muscle does. So if I have the infraspinatus, for example, and I had part of it on the infraspinous fossa and part of it on this part of the posterior greater tubercle, in order for it to shorten, that humerus is going to have to externally rotate. So try that as a strategy. I think it's really helpful to help students learn muscle actions. The other one is on complete anatomy, and we'll show you that later. How do we feel with bone marking so far? They're somewhat familiar. It's coming back. There's the terminology you've heard before, at least. Okay. Now on to the ligaments. So we have, and I'll do just the glenohumeral ligaments first. The coracohumeral ligament is going to go from coracoid process to the humerus. This is going to resist inferior motion of the humerus. It'll resist anterior motion as well. The more important ligaments we're going to talk about are going to be these capsular ligaments or the glenohumeral ligaments. And I'll show you a few different pictures of these. So you have three different bands. The top one is going to be the superior glenohumeral ligament, and this is going to come from that superior glenoid, and it's going to come to the lesser tubercle. This is going to resist anterior translation and external rotation when your arm is at your side. So at 0 degrees of abduction, if I were to externally rotate this humerus right now with it at the side like this, it's going to resist external rotation. As soon as we get past 35-ish degrees of abduction, now we've shortened this ligament and it's not going to resist that external rotation. Next is the middle glenohumeral ligament. It comes from the anterior superior glenoid, and it's going to come down to that lesser tubercle. So it is also going to resist anterior translation and external rotation, but in that 45 to 90 degrees of abduction position. So as we move the arm up a little bit, it gets a little bit more taut. And then the inferior glenohumeral ligament has three portions. It has the anterior band, the axillary pouch, and the posterior band, which is on the back side in the same exact spot. Of the three, the one that's most important for preventing anterior translation of the humerus is that anterior band. It's the strongest of them by far. Okay, so again, the anterior band, most important for preventing anterior translation, which is the most common direction that we're going to dislocate our shoulder. And you'll learn in later courses why that is. There's not as much bony coverage anteriorly, so we need stronger ligaments.
So is
This
that
one is
anterior band going to be the superior, middle, or inferior?
it's inferior. So the anterior band, the axillary pouch, and the posterior band are all part of the inferior glenohumeral ligament. I'll show you another picture as well that you can see that in. So
Yeah,
superior,
complete
middle,
anatomy
and then
doesn't.
inferior.
Complete anatomy doesn't have that axillary pouch, so this is a really great image of that. It is important clinically.
Yeah, so the axillary pouch, if we think about the concave convex roll, as I abduct, I have a superior roll and an inferior glide. So in order to glide, I need to have room in that capsule. So you see how it's wrinkly and loose right now? If that gets tight, if I were to shrink that and tighten it, I don't have full abduction anymore. And that's what happens with the frozen shoulder, or the technical name is adhesive capsulitis or adhesions of that capsule. So we lose that redundancy, we lose that slacken part of the axillary pouch, and then they don't have full range of motion. So that's where that comes from. The last ligament for the glenohumeral joint is the transverse ligament, and it's going to go from the greater tubercle to the lesser tubercle, and it holds the bicep tendon and the bicipital groove. So now I like this picture because it shows a little bit more of those glenohumeral ligaments. So you have the labrum, the glenoid labrum, which is the reddish color here. This is going to be fibrocartilage. It's going to deepen that joint capsule, have a little bit better contact area. Then we have the inferior glenohumeral ligament, the middle glenohumeral ligament, and the superior glenohumeral ligament. You'll also see the long head of the biceps here as it comes up through the groove and it attaches on that supraglenoid tubercle, but it also attaches into the labrum. And so this becomes an issue if we're rehabbing someone that has a labral tear up here and we contract their bicep, it's going to pull away and cause more tearing or cause disruption of that healing. This is a good picture here to show you as well the coracoacromial ligament. So what's weird about this ligament? What do ligaments connect?
Bone to bone.
Bone to bone. So what's weird about this one?
I mean, that's the same like structure. That's the
Yeah,
acromion and the core process.
yeah. So it's connecting two parts of the same bone. So it's a weird ligament. It creates more of an arch. So it's not serving to hold the bones together, but it's creating a functional arch to keep the head of the humerus from gliding superiorly and out of the joint. So if we look at it now, this is a little bit closer to what it actually looks like. We put the supraspinatus muscle in there. We put the bursa, which we're going to talk about in just a second. So that fluid-filled sac in there. And now we don't have very much room. So as we elevate our arm, we get that superior roll. If we're not getting that inferior glide, we get pinching under there. So if you guys have ever heard of impingement, that's what's happening. Those structures are getting pinched underneath that coracoacromial arch. So it's a very common issue that we'll deal with. But I like this picture. John, this is a good one for you, I think. I'm not sure which book this is from. I'm guessing Newman, but you can
It
see
looks,
that. Yeah, usually with a Newman, when I cut it out, it has black lines around it. But you can see that inferior glenohumeral ligament and then the three parts of it.
I have a question.
Yeah.
Um, so then is the coracoacromial arch kind of like synonymous with the coracoacromial ligament, or is it
So the
different?
arch is good question. Great question. So it's formed by the ligament and the acromion. So together they make an arch. And then I didn't talk about this in the other group, but people can have different shaped acromions. This one's pretty flat. They can have one that's curved and one that's more hooked, so it even further narrows the space that we have in there. So next I have a summary of the ligaments for you. So that'll be in the PowerPoint so you can see it. And for the bursa now, I need to move you guys out of the way again. So bursa are fluid-filled sacs. They help to reduce friction when a muscle or a tendon is moving over a bone. There are lots of them. They should make sense based on their name, but the most important one is going to be the subacromial subdeltoid bursa. Sometimes they're two separate ones on anatomy pictures. Sometimes they're all as one, but that's going to be the most important one. And then I have a couple slides that just talk about the different bursa. That's it for the glenohumeral joint. So what questions do you have about the structure of the glenohumeral joint before we move on?
I was gonna ask Dr. Ling, how does impingement occur at that
How does it occur?
y yes, like how is it caused? Is it due to
So
like
we
when they're grinding on the ligament?
More so the structures underneath the ligament. So the humeral head, as it rolls up, as we abduct, it should glide inferior. And so if that doesn't happen could be because of poor posture, could be because of weakness in the rotator cuff, could be just joint mechanics, that humeral head rides high. And so now it's pinching what's on top of the humeral head, which is the supraspinatus, that subacromial bursa, and it's pushing that against that subacromial arch. So under that acromion and under the ligament, and it just pinches, pinches, pinches with overhead motions. That bursa in the tendon become inflamed, which narrows the space down even more and then makes it worse.
Okay.
Yeah, so impingements, that language will be used in different places. You'll hear us mention it related to several other things. I mean, the median nerve passes through two heads of the pronator, and you can impinge there and cause trouble with wrist flexion. And when you hear the word impingement, you just think there's a narrow space and some kind of pathology. Movement problem has caused problems with the structures there. I know that impingement, David, also is an issue for that bursa that Dr. Ling mentioned, and that can create shoulder pain. Also, there's really no nerve or blood vessel that passes through that arch, but there's also the tendon of the supraspinatus is in there, and that's a really common rotator cuff problem passing over the surface of that bursa to attach to the greater tubercle right there. As far as I know, Dr. Ling, of course, I just listen to clinicians talk. I'm not one, but that supraspinatus tendon is like the most common rotator cuff issue.
It is, yep, because of that anatomy there. And you can imagine if we had a little bit of a curved acromion or if we had a bone spur under there, now we're going to have a little bone spur, a little tooth that's going to rub away at that tendon. And that's part of what can lead to rotator cuff tears. So more of a degenerative tear would be caused by that kind of thing. So you have some arthritis in the area, the little bone spurs just chew away at the tendon until it creates a tear. All right, now for the AC joint. So here's a clavicle from the top up here, and you can see the acromial end. It's very planar. So we'll see with the osteokinematics how that moves versus the sternal end. What kind of joint is formed by the sternal end of the clavicle. Sorry, for those that couldn't see Dr.
The
Warren, that's what I was laughing at.
for the clavicle, the sternoclavicular joint and the
Mhm.
costoclavicular joint.
What kind of joint does this form over here on this end? So we have planar joint at the AC joint. What does this look like? You can kind of vision that.
The saddle joint.
Yeah, absolutely. This is a saddle joint. And so we'll talk about the mechanics a little bit there. It's an S, the clavicle is an S-shaped bone, and you're most likely to get a fracture in that middle third of it. On the underside, we have the trapezoid line and the conoid tubercle. That's where the two ligaments are going to attach, which are very important. And we'll talk about those in just a second. This is a superior view. So this is the angle of the acromion that we were looking at. This is the AC joint, and then this is a good picture of the SC joint, which is why I put it in here. Okay, so let's talk a little bit about the mechanics of the AC joint. So glenohumeral joint, I think once you work through
Wait,
it a few times.
wait, Dr. Ling, wait.
Okay.
So I want everybody's attention for just a second here. So the capabilities, the movements that occur at the AC joint and the SC joint are by far the most common mistakes that students make on exam questions in this area. The glenohumeral joint, everybody can figure that out when you're talking about AC and SC joints. So what she's about to say, and she's going to continue on this on Thursday in the second hour, she's going to talk some more about this. This is super important for understanding the movement of the upper extremity, and it's not exactly intuitively obvious. So I know Dr. Ling's going to mention the video she's got here as well to help with this.
Yes, I'll put that in the chat after I'm done. But so I'm going to break this down. So start with just understanding the stuff that's in the AC joint and the SC joint slides. So those are a good place to start. Before I do that, let's talk about motions of the scapula. So we have elevation, which is going to be up, depression, which is down, retraction is moving in towards the spinous processes, and protraction is moving out. Okay, are we good with those so far? Next, we have upward and downward rotation. So if you think about that inferior angle and the way that's moving, upward rotation is going to swing up with that inferior angle, and then downward rotation is that way. Anterior and posterior tilting are going to be in relation to that inferior angle again. So anterior tilting, that inferior angle is going to come away from the thorax, from the ribs. That posterior tilting, we're going to bring it back to the rib cage. We doing good so far? The last one is internal and external rotation. So it's actually named by the position that the glenoid is moving, but think about the medial border tilting. So that's the internal and external rotation.
Could you
So the
give us an
medial,
example? Sorry, could you give us an example of like an action where someone is anteriorly tilting their scapula?
so this is a motion where, so it's hard to do actively. The pec minor does perform anterior tilting, but it's going to accompany other motions that happen throughout the spine, and you'll see that here in a minute. But someone that has tightness in their pec minor or poor posture can have that anteriorly tilted position, but it's part of normal mechanics with elevation. Does that help? Okay. But hard to do on your own, other than if you can isolate the pec minor, which I don't know if I could isolate the pec minor to anterior tilt. Maybe if I thought about it for a minute. The internal and external rotation, if we think about the medial border of the scapula popping off, what direction does the glenoid do? What direction does the glenoid go? So if you guys do that on your, take both your hands and you pop off that medial border, what kind of rotation happened at the glenoid? Internal or external rotation? So if I move that medial border away, the glenoid moves more towards the front. It's rotating more towards internal rotation. So if you think about internal rotation of the shoulder, it's rotating forward. So that medial border popping off is going to be internal rotation of the scapula. And the opposite, when we put that medial border back flat, that's external rotation of the glenoid.
Just so I'm clear, when you mean that it's popping off, you mean like it's coming away from the midline, like let's say away from the ribs?
Yes. So if we're looking at it from the back, this is the rib cage, and then we're popping off that medial border. So that's the tilting.
When I use the winging language here, Dr. Ling,
Mm-hmm. Yep, so that's a true winging. A lot of times we see that inferior angle will go away, but true winging is caused by the subscapularis or long thoracic nerve and happens when that medial border moves away, which you'll learn here shortly. So now moving on to the AC joint, because as I put here, movements of the AC joint are described relative to how the scapula is moving on the clavicle. Okay, so as the scapula is rotating up this way, that we just termed upward rotation, that's going to be upward rotation at the AC joint, and the opposite is downward rotation. Those are the big motions. Now we have these little rotational adjustments in the sagittal and the horizontal plane that are going to help to give us more motion. They're going to help to optimally orient that glenoid to allow us to fully elevate our arm. So like I just mentioned, that internal or external rotation where that medial border comes off, it's named by the direction the glenoid is moving versus that anterior and posterior tilting, which is named by that inferior angle, how that moves. So that's how we describe the motions happening at the AC joint. Upward rotation, downward rotation, internal rotation, external rotation, anterior tilting, and posterior tilting. All right, we feel okay with that so far? All right. Now on to the ligaments. So we have the acromioclavicular ligament, which is superior and inferior on the AC joint, stronger superiorly to support the joint. And then we have the coracoclavicular ligaments. And these are really important because this is what helps suspends the whole shoulder girdle onto our trunk. Without these, we don't really have anything holding our arm on because the scapulothoracic joint is not a true joint. It's just the scapula sitting against the rib cage. So these are super, super important ligaments for us. The trapezoid is going to be more lateral. The conoid is going to be more medial. If you've ever heard of an AC joint sprain or an AC separation, depends on which one of these three ligaments that I just talked about you're tearing. But imagine if I cut the acromioclavicular ligament, the trapezoid, and the conoid, that distal end of the clavicle is going to pop right up because there's nothing to hold it down. And that's why you see after an AC joint separation, people have that big bump there on their shoulder. Okay, now on to the sternoclavicular joint. So if you want to use your skeletons again, at the top, we have that jugular notch. The whole top portion is called the manubrium. You have a clavicular facet for the clavicles, and then you have a costal facet on the manubrium for the ribs, and you'll see the costal facets as you go down. So manubrium is the top portion, body is the main portion. Between them, you have a ridge that's called the sternal angle. So if you guys feel your jugular notch, and then you feel straight down, you will feel a ridge of bone. My camera's a little high, so it's hard for you guys to see where I am. So if you feel down right about here, that's where that sternal angle is. And then at the very bottom, you have the xiphoid process. So the xiphoid process isn't something that you can palpate, that you can directly palpate, but if you follow the rib cage, if you feel your rib cage up, well, you might be if you're super thin, you might be able to feel it, but it's not comfortable to palpate. So if you follow your rib cage up, you'll find that xiphoid process. It's right where they meet. So like I mentioned, the SC joint is a saddle. So let's talk a little bit about those mechanics briefly. So if we talk about the clavicle, that's going to be what's moving. So I have the concave and convex of the sternum as well, but what's more important is the clavicle. So that's what I would focus on. In a superior to inferior direction, the clavicle is going to be convex. So when we do frontal plane motions, like elevation and depression at the SC joint, you're going to have a convex moving on a concave. So the roll and glide will be in opposite directions. When we go medial to lateral, it's going to be concave. So when we do sagittal plane motions like protraction and retraction, you're going to have a concave moving on a convex. The roll and the glide will be in the same direction. And we'll go through this much more in detail on Thursday. But if you can understand that part, that's a good starting point. For the ligaments of the SC joint, you have the interclavicular ligaments, which are going to run from clavicle to clavicle, going to provide some stability for that superior part of the joint. You see there is an articular disc here in the SC joint. There is one technically in the AC joint, but it's variable depending on the person.
Yeah, evidently that's true in the SC joint as well. Complete anatomy does not have a disc in the SC joint.
Oh, okay. The sternoclavicular ligament is going to support and strengthen the capsule anteriorly and posteriorly. And then you have this costoclavicular ligament that has two separate bands, as you can see here, and they're going to run at right angles to each other. So it's going to prevent a lot of motion, provide a lot of stability to the clavicle. The only motion it doesn't resist is an inferior glide. So as I glide inferiorly, both of those bands are going to be on slack. So as I go to the summary slide here, this is a little bit of what we talked about. It's not important that you know the degrees, but just understand the motions and what those look like. So that would be super important for understanding for Thursday. So the scapulothoracic, those motions that we talked about, AC joint, SC joint, and then the glenohumeral joint. So understand all the different motions that occur, as well as which one is concave versus convex, which is going to matter for these two joints. So I have a few, I'm going to stop sharing. I have a few videos. I'll put them in the chat. The middle one does not have any, it's just music that plays with it and it has very little words, but I like because it shows you what that motion looks like. It really breaks it down and you can watch it and think about what the mechanics are doing. So it shows you glenohumeral versus AC joint versus SC joint. So it's the best video I've found so far. If I find one that I like better, I can give it to you guys, but I really like that one. So I would check out these two videos before class as well on Thursday. What questions do you have for me? So I'll put in the mechanics of the AC and the SC joint that were on that one slide, and then those videos.
So the anterior portion of the sternoclavicular ligament is going to limit excessive anterior translation, while the posterior does the posterior
Yes.
translation. Okay.
Yep.
Okay, before you guys take a break, I wanted to see how we're doing with sharing screens. So I'll just start up here at the top. Gina, do you have complete anatomy open on your screen?
Yes.
Would you share your screen and let me walk you through a couple of things here
Okay.
so everybody can watch?
Stay share and screen. Okay. Can you guys see anything?
Not yet.
Okay, let's see. Here we go, share.
Good.
Okay, allow. Okay, so here we go.
Okay, beautiful. All right, so just a couple of things here that will be helpful. The first thing is when you want to find something, you can search for it, but you have to be careful when you do that because after you search for 5 or 6 things, a lot of times complete anatomy will lock up on you.
Yeah.
It's better to use the menu buttons on the bottom of the screen. So we'll search for the nerve names in just a moment, but when you want to do muscles, if you go down to the muscular button at the bottom of your screen
Okay.
and click on the plus button and hold it down, it'll put all the muscles there. And then you can start in superficial to deep removing muscles. So if you'll just click on the pec major there
Okay.
and hit hide on the left, then you can see the pec minor, ribs 3 to 5. Click on the platysma there, just superior to it. Yeah, remove, hide. Yeah, and then the deltoid to the right, hide that one.
Does it matter which part or just?
It does, and I just wanted you to
Okay.
see functionally how to do that.
Yeah.
And we'll do the same thing with nerves and blood vessels as well. And so I will expect when we come to class on Thursday that you can open Complete Anatomy, share your screen, and do the topics that we're not finished. We're not going to finish today.
While she's sharing her screen, can we show the motion?
Yes. So let's do one that we've been talking about already. Let's do the bicep.
Okay.
Yeah. Okay. So on the left-hand side over there, use the arrows to move. Okay, good. Motion. That's good. And then, okay, flexion. Now, we're not going to do this during our class time because it takes too much time to download and wait for that for each of the muscles.
Other than the rubber band, this is my favorite way to have students learn muscles. So this is showing you, because she clicked on the shoulder flexion, which is one of the actions of the biceps brachii, it's showing you all the muscles that do shoulder flexion. If you look on that complete sheet that I put on Teams at the bottom of the chart, it'll say primary shoulder flexors, and it'll have a list of all the shoulder flexors. So this is a way you can go in and then visualize what those are because we're all very visual learners. I think we would agree. And then we can see the motion. You can see the muscle shortening as it does it. You can see its origin and insertion.
Thank you, Gina.
Okay. Yeah.
Will you
I wasn't sure which one.
if you'll
Okay.
unshare your screen, we're going to try one more student.
Okay.
Thank you. CJ, would you share your screen?
Sure. Let's see here. There.
I like the enthusiasm, CJ.
I'm just hoping that it works because complete anatomy has been slow.
And now you know how we feel every time we go to use technology.
Yeah.
We just hope it works. And sometimes it does, and sometimes it doesn't.
Yeah.
Okay.
While
I
this,
figured out what was happening in immersion, by the way, when Dr. Warren had to keep my computer alive. I had a setting that when I walked away from my computer, it turned off. And so every time I turned my back, that's why the screen was going off.
Wow.
okay, looks like CJ, looks like you've been working on this already.
Mm-hmm.
Yeah. So let's just show everybody one more really useful function here. See all the work he's done. He's labeled a lot of really important structures on this image. On the right-hand side of the screen, near the bottom, there's a plus button that says Save Screen. CJ, if you'll click on that for me.
I've clicked on it 5 times.
Mm-hmm. Seems like it's locked up.
Mm-hmm. Whenever you said you use the search bar and it freezes up.
Yeah.
Mm-hmm.
You've just experienced that?
I think so. Let's see here. Save? Okay.
Yeah, there you go. Now you can give it a name, so you can remember your work. But this will be very useful if you come to class on Thursday and you've already done some work and you have these images prepared, then it'll greatly increase our efficiency at learning in class on Thursday together. So these will stay in your library. You can put them in folders. You do, so that you can have them later. Really useful tool.
Can they share their folders that they have?
They can. That has created some issues in the past. I don't normally do it because of that. Whenever we share folders, sometimes students have got different issues with their images and things are left out, and then people learn images that don't have all the labels, and then I get blamed for it. So let's just make our own images, and we'll point out the structures you need to know there. If you'll do some of this work before Thursday, that would be great. Thank you, CJ. If you'll unshare your screen.
Sure
They could
thing.
make an image to test a classmate though, then if they could share it, one with
Sure could.
that isn't labeled.
Yeah, in
You could
fact, we will do
try to
that.
stump your classmate.
Yes, we'll do that in both Anatomage and Complete Anatomy during the immersion time together. We'll have you doing presentations to your classmates with these two packages. And then we'll have you testing each other with those packages, especially with regards to the upper extremity during the first immersion time. So, and then you'll have actually lab exams with those two tools also during immersion. That'll count as part of your 30% of your grade. So yeah, this is going to be really important. So get comfortable with Complete Anatomy. Last thing I'll say before I let you go, just a couple minutes here before the 150 mark, concerns the attachments and the spinal segments for nerves. So we're about to take a deep dive into spinal segments for dermatomes and myotomes. And the number of data points that you have to remember is going to increase exponentially over the next couple of hours that we spend together. So not all textbooks or research articles agree on spinal segments for dermatomes and myotomes. There are at least 3 standard dermatome maps that we have in the literature right now. And the one on Complete Anatomy doesn't actually fit any of them. So here's the way we handle it. For muscle attachments, please do not simply memorize the names of their origins and insertions. You're not going to have a test question that requires you to know that the insertion moves toward the origin. That language is confusing. What we want you to do is to be able to take your hand or your thumb and put it on the bony part where the muscle attaches. It goes there and it goes there. It goes to the top of the glenoid cavity. It goes to the radial tuberosity. It's the long head of the bicep. We want you to be able to tell us where it attaches. So there should be, normally there's a proximal and distal in that language, but Dr. Ling and I will ensure that the descriptions of origins and insertions and the spinal segments for dermatomes and myotomes and muscle innervations, where there are disagreements in textbooks and Complete Anatomy, visible body has its own issues, where there are variations, those will not be required for you to distinguish between. In other words, a test question, I'll just take the dorsal scapular nerve. Okay, so this is the one that comes off right off to the roots, hits the superior trunk and the brachial plexus, and it goes straight through the suprascapular notch to the supraspinatus and infraspinatus. And sorry, that's suprascapular. Dorsal scapular. The dorsal scapular comes right off where I said, and it runs right down the medial border of the scapula, picking up the levator scapula and the 2 rhomboids. Now, if you look in your book, it's going to say C4, C5. In the clinical more text, it'll have C5 in bold. The students want to know, do I have to know all of the bold ones versus the non-bold segments? And the answer is, we would never ask you in a question, tell us the spinal segments innervating the rhomboids. And one choice would be C4, Another choice would be C4, C5. That's not going to happen where you have to make a decision between those segments when there are disagreements in the text. I am going to teach you a spinal segment mechanism that is very straightforward and is standard protocol. If you will trust me, this marks 31 years for me. You will trust me in teaching you how to learn these. You will remember them for your lifetime. So that's going to be one of my main pushes during the second hour today, to give you a mechanism to do that with. And I like to use the spine. I like to use the spine as the launching place for learning where nerves are, what muscles they control, and what the joint actions are. I will speak them. I will model that for you in the second hour today. On Thursday, you're going to be expected to do it with complete anatomy in front of your classmates the way I'm modeling it for you today in class. All right? Let's take 10 minutes, and when we come back, I'm going to do a little review and recap. Actually, recap. Yes. And then with cervical plexus, and then we're going to dive in to the beautiful world of brachial plexus. Y'all get some water. 10 minutes. All right. So all of you will rejoin me, please. Thank you very much. So the goal here is for the first 15-ish, 15 to 20 minutes-ish, the goal is to do a kind of review with some additional information to help start building out our dermatome and myotome thinking in terms of spinal segments. And then for the head and neck specifically, it's not presented this way, I know, in your asynchronous video. The asynchronous video does this as separate categories. We're going to learn head, neck, shoulder as a narrative, a single unit story to think about things. And I'm going to use the spine, moving from C1 down the spinal cord as the guide. So if you will do it that way, if you will learn nerves and muscles and joint actions using the spine as your benchmark, it will make it much easier to remember these things. Okay, so I'm going to share my screen. If you'll just listen for a few moments here, I'm going to talk cervical plexus, mention some things that was not in the asynchronous video to give you a global view picture, show it to you in complete anatomy. Then we're going to start the brachial plexus together and make our way through. The 4 joints of the day are scapulothoracic, sternoclavicular, acromioclavicular, glenohumeral. These are the ones we need to understand in terms of how they move. But our job between now and the time Dr. Ling starts talking again on Thursday in the second hour is to learn all of the fundamental anatomy, the muscles and their innervations that explain the joint actions that she's going to talk about. I'm going to use the words as I'm going through them, but then she's going to re-emphasize those for you on Thursday. And so hopefully collected between the two of us doing this together with you and you're presenting them, you'll learn them in a way you can remember them. Okay. So that's 3 minutes of intro. I shouldn't have taken quite that long. Let's share screen. All right. Okay, so this first image is, let me see if I can get these out of the way because they pestered me to death in the first. Yes, that's working. Okay. So this first image is not one that I've used in class. It's a way of summarizing things that we've learned. So this was on your exam, right? The trigeminal nerve, the things that pass, the different branches of trigeminal nerve and what they pass through. So remember, this nerve has 3 branches. Okay. V1, V2, V3. And this one, V3, was the only one that had a motor component to the muscles of mastication. We did not look at the details of the temporalis or the medial and lateral pterygoids or the masseter. We did not look at them together. It's not that they're not important, just this class doesn't emphasize those things. V1, V2, V3, we think of as sensory mainly nerves. V1 is sensory only. Remember, it passes through the supraorbital fissure. And it's sensory information from this area of the head. So here's a frontal view here. And here is a lateral view here. V2 of the trigeminal is here. Upper jaw, maxillary branch through the foramen rotundum. And then V3, sensory information, is here. It runs, the auriculotemporal runs all the way up here on the anterior portion of the ear, and it covers the lower jaw. So I know it's silly, but I do it anyway. If I do my head like this, I go sensory information. I knew this already. V1, V2, V3. Now you also know if I start talking about the posterior aspects of the skull, we did the suboccipital triangle in detail together, and you learned that the suboccipital nerve is the dorsal or posterior ramus of C1. Did you hear C1? It has begun. C1. Now this one, remember, is the somatic motor information to the muscles of the suboccipital triangle. Passes through that triangle with the vertebral artery. Notice that it is not represented in the sensory story of the skull. So up here in the front and across the top, I'm V1, V2, V3. Now I want to talk about the back of the skull. And here I'm going to talk about the greater occipital nerve and the third occipital nerve. So this is a pretty good view right here. Let me show it to you in complete anatomy so you can get the big picture here. So if I put the nervous system on here, did y'all see what I did there? Don't search them. So here I'm on the back of the skull here, and notice from medial to lateral, I have C3 and I have C2, the third occipital and greater occipital nerve. The dorsal rami of the third and greater occipital nerve, these are the ones that are responsible for the sensory information on the back of my head. You want to do it now? V1, V2, V3. And now put your hand back here and you go from the middle, C3, lateral, C2. Now notice there's another one here on the skull. This one is called the lesser occipital nerve. So it's third, medial to lateral, C3, greater occipital, C2. Those are dorsal rami. And then this one, the lesser occipital nerve, but there's been a switch that has happened now. This nerve, the lesser occipital nerve, does not come from the dorsal rami. So you have a complete story now for the dorsal rami of C1, C2, C3, right? Dorsal ramus C1, muscles of the suboccipital triangle. Dorsal ramus C2, C3, lateral, medial, back of my head. I've almost got it covered now. I need to work my way around the lateral portions of the head to the back of the ear here for sensory information, but we've made a switch. So let me show you what that switch looks like. This picture is from a different book, I know, but it is a great summary picture to talk about the cervical plexus. So there's no particular lecture covering cervical plexus and the asynchronous, I know. Okay, but I'm going to do some silly things here, silly little phrases. You know, LR6SO43, everybody knows what that means, right? LR6SO43. Y'all can talk about external muscles. We're going to do similar stuff here. Stupid little things we repeat and we remember forever. Repeat them and remember them forever. So now we're talking about ventral rami of spinal segments. And we're in the upper cervical here first. Yes? Working our way down the cervical cord. And it sounds like this. 2, 3, 2, 3, 2, 3, 3, 4. 2, 3, 2, 3, 2, 3, 3, 4. This is anterior rami, spinal segments, sensory information from the skull and the top of the shoulder. So dermatome information here. These are all sensory nerves as part of the cervical plexus. By name, lesser occipital. Do you know about a third and a greater occipital nerve for sensory information from the head? Yes, you do. Those are C3, C2, medial to lateral. So lesser occipital gets 2-3, greater auricular, I'm at the ear. Behind the ear, really, in front of the ear is maxillary branchial trigeminal. 2-3 for transverse cervical, name for where it goes. 3 branches of supraclavicular across the top of the shoulder here anteriorly. 2-3, 2-3, 2-3, 3-4. This is a picture from the Morse clinical text that you have showing these and their locations. So I'll start with lesser occipital, and you can see the lesser occipital nerve and the area it's getting sensor information from. Spinal segments, everybody just says them, right? The answers are 2-3, 2-3, 2-3, 3-4. 2-3 lesser occipital here. The next one is the greater auricular, moving to the back of the ear, picking up some of this stuff here. So from this point forward, in the upper jaw would be V2 of trigeminal. So here across the ear to the posterior aspect, this is greater auricular. Spinal segments, 2-3, 2-3, 2-3, 3-4. Next one is the transverse cervical. Where does it go? Transverse cervical, transverse cervical. Across the anterior and lateral neck here, sensor information. Spinal segments, 2-3, 2-3, 2-3, 3-4. Am I being stupid enough here for you? Is it sinking in? Supraclavicular with 3 branches, middle, intermediate, and lateral. And this is the sensor information from the anterior and lateral neck across the top of the clavicle. You know, supraclavicular. These are the 4 major nerves, sensory only, of the cervical plexus. Now, you also know from what you've learned from me earlier that the trapezius muscle and the sternocleidomastoid muscle are innervated by the accessory nerve. We are not going to go back through all the actions of the 3 parts of the traps or all of the actions of the sternocleidomastoid. You were responsible for that on test 1, and you will be responsible for that for the rest of your lives. Now, this includes trapezius and sternocleidomastoid as part of what we're calling the cervical plexus. Now, how can that be? I thought you told us, Warren, that the innervation of the traps and sternocleidomastoid was from the accessory cranial nerve. How can these things be true? And the answer is because the segments, the actual motor information that travels to these muscles comes from the spinal cord. So technically, cranial nerve 11 is part of the cervical plexus. See that? In addition, we're going to pick these up over the course of the next 2 hours of our lives together. The scalenes we've talked a little bit about. They're going to be an important benchmark muscle for us. They are involved in movements we're going to talk about. The levator's going to come up today. We're going to get there today. But you see, these say that they're coming from cervical plexus. So what you're going to learn today is that the innervation of the levator scapula, and this is going to be in your textbook as well, and the rhomboids are innervated by C4 and C5. But in the image you're going to learn it in, it only has the C5 root to the superior trunk going to levator scapula. This would be one of those where you're not going to be punished for learning it either way. You're going to learn levator scapula as part of the innervation pattern from the brachial plexus. It's a border muscle, right? There's not a definitive line at C4 and nothing below that for innervation. So I love this table. It's a really good, concise summary of the cutaneous superficial dermatome story and the stuff that we will use to construct myotomes with the deep branches, motor branches of the cervical plexus. This is C1 to C5. The unit that we're doing this week is intended to bring you from C5 to C7. C5 to C7, that's what we're doing this week. And so what I've done is I've constructed for you a list. So we do every single one of them the same way. A list of the nerves that are going to be involved in moving the, do it with me, scapulothoracic, sternoclavicular, acromioclavicular, and glenohumeral joints. This is the summary story, these 8 nerves, for the movement of the joints that we're talking about this week. And they are primarily, so I'll just circle the exception, they are primarily coming from C5, C6, and C7. Now, before Thursday, I was tempted to say we need to have a test on this just to prove that they've done it. This is the Wade-Warren version of the brachial plexus. It will, memorizing this picture will be useful in answering a significant portion of the questions on exam 2. We don't normally ask you just to memorize things, but this is one of them. You need to memorize this picture before Thursday and remember it for the rest of your careers. Dr. Ling, would you nod? This is important for physical therapists. The brachial plexus, this is the story of the upper extremity. You unmuted. I thought you were going to add something there.
I was just going to add, if they're having trouble drawing it, there are a million videos that you can watch that describe different ways. If this is something you just have a mental block on drawing. But yes, you should be able to draw this, and you should be able to draw it fairly quickly.
Quickly. You need 5 colored pens or pencils. Buy them in the dry erase form for your exam, so that when you start test 2, you reproduce this image at the top of your whiteboard so that you don't have to rethink it every time you read a question asking you about spinal segments. You can very quickly reference it, and your brain immediately knows what to think about the question. So today, have you heard me already say this? The dorsal scapular, the suprascapular, the lateral and medial pectoral, that's a little exception there, the axillary nerve, the upper and lower subscapulars, thoracodorsal, and the long thoracic. 1, 2, 3, 4, 5, 6, 7, 8. 8 main nerves. The one at the top, that was for last test, but you still have to know it. It's cranial nerve 11. The accessory nerve goes right up here. So this is the story of C5, C6, C7, and the movement of the 4 joints that we're interested in. All right. Now, in your presentation, the PowerPoint presentation, you will see tables with all of this information in them for the muscles. That's not the way we're going to learn it. We're going to learn it as a narrative using complete anatomy. So I am going to model the first 4 of these for you in the way that I will expect you to model the last 4 and the artery story when we come to class on Thursday. Everybody nod, you got me? I'm going to show you right now what I want you to do when you come to class on Thursday with your assignment. Okay, so we're going to start here with the axillary nerve. So I go to complete anatomy, follow the sequence now. Let me just clear everything first. Hang on, get it all off of there. Get it all off of there. I don't want any of that stuff on there. Oh, let me show you one more thing while I'm here. I just thought of this. It's not time to memorize these yet, but if you click integumentary and hold it down, can you guys think with me? V1, V2, V3, C2, C3, C4, C2, C3, C4. Could you name some nerves for me? Third occipital, greater occipital, dorsal rami, lesser occipital, greater auricular, transverse cervical, supraclavicular, 2-3, 2-3, 2-3, 3-4, Now, this map on complete anatomy doesn't fit exactly what I just said. Some of you saw that. But it's very close. And if you remember the stupid little sayings that I've given you, it'll really help you with your dermatome stuff. All right, get them off of there. And let's do a model. Get all the connective tissues off. All right, now I just got a skeleton on here. So first thing I'm going to do is I'm going to search the nerve. What's the nerve I'm looking for, y'all? Are y'all sleeping?
Axillary. Oh, yeah.
Thank you, Lillian. The axillary nerve. And I'm going to do the one on the left here. You can do left or right, I don't care. Take the search button off. If you don't click the search button off, it'll lock up on you. CJ, have you found that when you're doing it? Yeah, so take it off, take the search button off like that. So the first question here is, where is that nerve? Now, Dr. Ling mentioned this just very briefly. She mentioned the anatomical neck here around the head of the humerus is an important structure, and the surgical neck here of the humerus. A fracture on the proximal end of the humerus. What does this mean? Okay, so I bring things up like that so you start thinking about it. You're going to learn where these nerves are. I'm going to teach you the basics. You're going to teach each other the basics, and then you can apply a million different scenarios. Where's the axillary nerve? Well, in this picture, it looks like it is running, the axillary nerve is running along the medial aspect of the surgical neck. Now, you're going to describe it things like that. I'm going to bring up other stuff as you're doing these things for really famous anatomical landmarks, etc. So if I go and drag this one over here, if I put some muscles on here now, too many things in the way. Put some muscles on here, click. You see me on the muscle thing? Click, click. Uh-oh. It just disappeared. The axillary nerve's gone. I see it. There it is. One more. One more. Okay, now it's gone. Now I look on my table. I discover the axillary nerve is responsible for innervating the deltoid muscle. Okay, so let's talk about that in just a moment. For now, I'm going to take it off because I want to know where it is. This is a very famous location in human anatomy right here. You see the axillary nerve is emerging in a little triangular space. I'm going to draw it. Very famous anatomy location here. You see this little square. This is called the quadrangular or quadrilateral space. There's an important artery in there that you're going to learn when we do the arteries on Thursday. Now, I get that off of there, and I'm going to describe where the nerve is. It's running along the medial side of the surgical neck, the humerus. Okay. Where? Well, it's in a little square right there, and that little square is created by the teres minor on top, the long head of the tricep medially, the teres major on bottom, which is going to be a marker for our axillary artery as well, and the humerus. So these are the borders of the quadrangular space where we're also going to find an important artery supplying this joint and the proximal end of the humerus. It's a really important spot right here. Where's the axillary nerve? Now you can explain it. Okay, well, what does the axillary nerve innervate? The answer is the axillary nerve innervates
The deltoid and teres minor.
go, man, you go. So it innervates the deltoid and the teres minor. So we're going to put all these muscles back on here. And we're just going to do the deltoid right now. We're going to return to the teres minor later because we're going to do all the rotator cuff muscles together. This gives us an opportunity to repeat ourselves. So the deltoid muscle here has 3 attachment sites. Listen to the way I describe attachments. The clavicular part of the deltoid attaches to the clavicle and the deltoid tuberosity. It's lateral on the clavicle. It is involved in flexion. It is involved in flexion at the shoulder. It is involved in medial rotation at the glenohumeral joint. With a number of other muscles. As they bunch up on us, I will ask you while you're giving these presentations to name the others, and I'll help you with that part. The acromial part of the deltoid here is attached to the acromion. That's its name, and the deltoid tuberosity, which you saw today. This one has as its primary action abduction. The posterior part of the deltoid here is called scapular. It's attached to the spine. It's in the back, so it's on the spine of the scapula and deltoid. This one is involved in extension of the shoulder, lateral rotation, and transverse abduction at the glenohumeral joint. So here I've got a muscle innervated by a nerve that can do antagonistic functions. There's a cool question right there. Flexion extension done by the same muscle here. So you got to have ways to slow one of them down, antagonistic muscles. You guys learned enough in test 1 to be able to explain that. This is not on test 2, so we're not going to go back through it. So there's your deltoid right there, innervated by the axillary nerve. Let's have a look on the picture. Every time after you have done the nerve, its location, the muscle and its action, then I want you to go back to this picture every time and talk about spinal segments for me. So in this picture, I see the axillary nerve as part of the terminal branches of the brachial plexus. So now is the time to learn it. This is the first one, and it includes all of them. So I'm going to say it. The brachial plexus is made up of pathways that can be followed in the language of roots, trunks, divisions, cords, terminal branches. Yuck. Really tired, drink coffee today. Really, roots. Tired, trunks. Drink, divisions. Coffee, cords. Today, terminal branches. If you've drawn this out, the reds and the greens, you've taken them out to the axillary nerve here. And so if I ask you what spinal segments are responsible for, now we're building myotones. You know that 5 and 6 are going to be involved in shoulder flexion and extension and abduction. C5 and C6 just by way of the deltoid. Now, a student pointed out in the first class, and she's right, that the divisions, the anterior and posterior divisions, are not listed in the asynchronous videos. And I get that. That's fine. Divisions are not going to show up on your test. That's cool. But I just can't leave you without it. You don't have a brachial plexus story if you don't know about the divisions. Can I just give you one example here? Let me give you one example. You may think, a student may think, let me show you this. If you track the axillary nerve back to its origin, you will note that the axillary nerve comes off of a segment of nerve material called the posterior cord. Now, would you please notice here in this image that the posterior cord here has red and green and purple and aqua all represented. Do y'all see that? So if all you did was memorize this picture and the question was, what spinal segments innervate the deltoid? You might be inclined to say C5, C6, C7, and C8. Do y'all see that? But there is no C7 or C8 contribution to the deltoid muscle. It's all from 5 and 6. That's why you need color coding in order to understand the spinal segments that innervate particular muscles. How's everybody doing? I got thumbs up. Okay, thank you. All right, so if I got thumbs up, I'm sorry, Lily, you gave thumbs up, so I'm gonna let you help me a little bit here, okay? All right, so let's do number 3 here, the dorsal scapular nerve. I'm gonna go to complete anatomy and take everything off. Give me just a second. Okay, Lily, tell me what to do. You're putting together your presentation for Thursday. I want to do dorsal scapular. Tell me what to do.
So first search the nerve and
Okay.
click on it. Okay, click on it. Now exit out of the search bar. And then we can look at where it's at, describe where it is.
You want to take a stab at it?
Yeah, it's gonna be along the medial border of the scapula.
That's beautiful. That's exactly where the dorsal scapular nerve is. From the image on the PowerPoint, if you have that open on in front of you, what spinal segments feed this nerve?
They're gonna be 5.
And some textbooks will also include C4, but C5, that's what we're going to learn. C5. It's the first one off. And where does it come off? Roots, trunks, divisions, cords, terminal branches?
The upper trunk.
Yeah.
Yeah.
Comes off the upper trunk. Exactly. When I say root, what comes to your mind?
Whether it's the upper trunk, middle trunk, or lower trunk.
Okay, good. I'm glad I asked because this is a point of terminology. Anatomy people are crazy, yeah? I mean, where we have something with one name, let's give it 4. It's the mitral valve. It's the left AV valve. It's the bicuspid valve. You know, let's give it 4 names when we can give it 1. Or anatomists do crazy things like, I know what let's do. Let's call them Purkinje neurons and the ones in the heart Purkinje projections. Same name. Craziness. Anatomists are crazy. Okay, so here's another one. This is another crazy anatomy thing. In this image right here, Lily, these things right here are the roots. And students, with good reason, when they hear the word root, they think dorsal and ventral roots in the vertebral foramen connected to the spinal cord. That's not what this is. These are actually the ventral rami branches of the spinal nerves. We are outside of the intervertebral foramen. So I'm sorry, but this is the language you have to learn. A root can be dorsal or ventral attached to the cord. But in the brachial plexus, a root is an anterior ramus of a spinal nerve. Everybody got that? Point of confusion.
So, Dr. Warren, so
Yeah.
that dorsal scapular nerve, it's not a trunk yet, because that's the first one that it comes off of.
Yeah,
So
it comes
is that just coming
right.
off the C5 root?
Yeah, right where the root, and Lily's right. It's right where the root meets the trunk. So I would take up upper trunk there. That would be fine. Root or trunk there for C5. And there's some stuff that normally comes off 4 as well. So, all right, Lily, you ready? Put the complete anatomy back up here. Where's the nerve? It runs right along the superior angle and the medial border. Now, if you describe it like that, then you know already what muscles it's going to innervate. All right, Lily, tell me what to do next.
Now you can add the muscles.
All right, I'm going to add the muscles. Next.
Next, probably need to get rid of some of them.
And now, how did you know that?
Because it's on the other side or the anterior side of the scapula.
Okay, let me tell you how to cheat. Okay, when you click on the nerve on any one of these nerves, on the left-hand side of the screen, it's going to tell you the muscles that it innervates. So when you're doing your prep work, make yourself some images with those muscles already there. Or you can look at the table in the PowerPoint figure that I gave you, and it'll tell you what nerve innervates, what the muscles are that this nerve innervates. Okay, let's look at them. You're right. Take the traps off. There's the superior border right there. I actually see the nerve right there. Do you see it?
Mm-hmm.
This is an anatomical phenomenon. If you want to find the nerve that innervates the muscle, it will almost, not every time, but almost every time, it'll be deep to the muscle. It's going to be deep to the muscle. That's where the nerve will be, running along the medial border. All right? What are the two muscles it innervates?
The rhomboids and the levator scapulae.
Yeah. Yeah, the levator scapula. So here it is, superior angle. Here, listen to my attachments. Lateral attachments in the cervical cord, superior angle of the scapula. Lateral attachments in the cervical spine, lateral attachments in the cervical spine, superior angle of scapula. Now, if you know that's where it goes, you can contract it in your mind and get the actions. Here they are. Elevates, downward rotation at the girdle, acromioclavicular, sternoclavicular joints, extends and laterally flexes the neck at the cervical vertebral points. All of those should make sense if you know where the muscle goes. Now you got a whole story, right? I'm C5, upper trunk, running along the medial border of the scapula to the levators. And this is what it does because it attaches to the lateral cervical spine and the superior angle. What's the other one?
The rhomboids.
Yeah, so there's two of them. So we can put them together, rhomboid minor and major. These muscles attach to the spines of the thoracic bones. The spines of the thoracic bones, upper thoracic spine attachments here. And to the medial border of the scapula. The medial border of the scapula is dominated by nerves innervated by the dorsal scapular nerve, levator and rhomboids. The rhomboids, however, importantly to note here, are attached at an angle. They're attached at an angle. They're attached at a down angle from the thorax to the scapula. So whenever they do their actions, they retract. Does that make sense? They're going to pull the medial border toward the spine of the thoracic bones. Some call that a deduction of the scapula. I like retraction. And because of their angle, they're going to cause downward rotation at the acromioclavicular and sternoclavicular joints. Does that make sense? Which way does the inferior angle of the scapula go whenever the rhomboids contract? Which direction does the inferior angle? That's right.
Medial.
Yeah, medial and
I would say down and back.
Superior.
Like this. Go like that.
look, John, this part right here goes that way. Yeah. So if you learn the attachments, you describe them in that way, then you can tell what the muscles are doing at the joints. Is that helping? Is everybody seeing the organization of this? Nodding everywhere? Okay, let's do one more. I forgot, Dr. Ling, did we get to the fifth one in the first? I can't remember.
No, we only got through the first three.
Okay.
They had 4 through 8 to do for the
Okay,
next class.
so let's stop there. We're about 8 minutes ahead of the other group. You guys will start your work here with the medial and lateral pectoral nerves. This is a pretty big story because look, the lateral pectoral gets 5, 6, 7 off the lateral cord, but the medial pectoral gets 8 and T1. What are you saying about the pectoralis muscle? Okay, so that's where we're going to start our discussion on Thursday. And you guys will have some prep work done. We'll try to get through in the first 30 minutes or so, 4 through 8 right here. You guys will be ready to go with your presentations. We'll share screen, go. And whatever you say that I want to add something to, or Dr. Ling wants to throw a little nugget in there, we'll throw it in there to help you. And then during the second 30 minutes of my time with you, we're going to do the vascular story. This one won't take as long because a lot of this stuff will have come up. For example, you guys already know something about the quadrangular space. And so we're going to find what nerve's going to be in there? 5-6 terminal branch. Axillary is going to be in there, but you don't know the artery and vein story. And so I'll point out some of these important landmarks for you. The pectorals will be another one here. So this deltopectoral triangle, really important. We're going to find, this is going to be at the beginning of our talk on Thursday. The lateral medial pectoral nerves are in that triangle and named appropriately, although anatomically it's confusing. So I'll make those points for you. We'll talk about what the pec major does, and then we'll move to the next one. And toward the end of it, I'll make some big summary statement and I'll go 5, 6, 7. Tell me what they do. 5 to dorsal scapular off upper trunk. And then we'll keep spewing these things out about the brachial plexus until we can remember them well. So please trust me. If you learn it this way, you'll never forget it. Let's use the spine as our starting point. And we're going to work our way down 5, 6, 7, 8, T1. And y'all, that's the next exam. 5, 6, 7, 8, T1. Another test. That's what we're going to do. All the way down to the tips of the fingers. And so this picture is going to come up dozens and dozens of times as we do our journey through the muscles that move the various joints of the upper extremity. So we've gotten through about half of the big ones that move the AC, SC, glenohumeral joints. We'll cover the other half in class at the beginning on Thursday, and then we'll do arteries, and then I'll stop talking, and Dr. Ling is going to start talking about biomechanics. And if you've learned all of this stuff, then the biomechanics is going to be like so logical once you've learned where the muscles go and where the nerves are. So, all right, any questions for me from any of you today? I do appreciate CJ, Lillian, for your help. And more of you are going to contribute to our conversation on Thursday. But we wanted to give you all a break today.
I have a question. So I know Dr. Ling, you mentioned that for that image, you said we could look at videos to be able to understand it better. What would we search?
I put them in the chat.
Oh, that's okay. Thank you.
You're welcome. And it's the middle one that has no, doesn't really have any narration, but you can visualize the motions really well on it.
We have about 4 minutes of class time left. If you have any questions or anything for us, please bring those to us. Everybody understands what's going to happen on Thursday. Y'all have a good afternoon.
Really, I have a question kind of going back to the pouch. I know you said that when it's smaller, we can't get enough inferior glide, so we get impingement. How would you go about
We don't, not that you get impingement, it limits your motion. So that's what causes adhesive capsulitis.
yeah. So is there some way, I know we talked about doing like holding long loads to where the ligaments can reorganize and everything. Is that something we could do there to help re-get
Yes.
in the patch?
Yep.
What
You
does
do
that
low load, long duration, and you do just holding at whatever their motion is. Wherever they're limited in motion, you can prop them in there. You can put them in extra rotation and some abduction. Use if they're laying down, use a TheraBand to help hold it there. And doing joint mobs. Doing that inferior glide with a joint mob to help stretch back out that inferior capsule, that axillary pouch.
Okay. And how would you test for that? How would you determine if it's an issue there?
So just like you perform a joint mob, you do the same thing to assess the mobility in each direction. So that's something that you'll learn throughout the program is to assess how much mobility there is in the capsule and where it's limited.
Okay, makes sense. Thank
Yeah,
you.
you're welcome. There's also something called a capsular pattern that you'll learn about. And so if range of motion is limited in a certain order, if certain motions are limited more than others, it tells you it's the capsule that's restricting it. And so then you really want to focus on those joint mobs versus if muscle length is or pain is inhibiting the motion. Lots more to come.
Thank you.
You're welcome.
Thank you.